But this whole idea about personalised medicine or precision medicine isn't only in the cancer domain, it's in a lot of different domains. And I think we're at this sort of inflection point in medicine now where there can be some real change with the way we go about helping the community and treating our patients. And just for full disclosure, I'm not a medico, I'm a PhD trained, so don't give any clinical advice, but obviously working at Peter Mac, and I've been there 25 years now, things seep in, and I've got a lot of clinical colleagues who talk to me about this, and I sit on the hospital executive, so I hear about this sort of stuff all the time. So the topic of the talk is around personalised cancer care, and really it's about where we're at with this whole concept. And are we ready for it yet? It's an interesting sort of idea to think about, and maybe you can make your mind up at the end about whether we are really ready for it yet, and just where we're placed. So what's with all this personalised cancer medicine stuff? So there were actually 2 articles in the Age that came out in the last 2 weeks that spoke to this. So on the left-hand side, there's an article that talks about a charity urging tests for new cancer treatment. And if you read the article, it's around using genetic testing to then define how a patient, and the patient is listed there, may be treated, because the previous treatments hadn't worked for her, and her disease had genetic mutations that weren't really common for that sort of that form of cancer. But there was a mutation in a gene that we had a medicine for a different sort of cancer, and so they now applied that treatment for her, and she's had a very good outcome. So that's the basis for that one. And then on the right-hand side, this is a study that's come out of Monash University, where the whole idea is that you would do laboratory testing on the very cancer cells from a patient, and do some laboratory testing for drugs that may work or may not work before that patient is ever treated. So take the cancer cells out, grow them in a dish like Davo used to do when he was a young fella doing his PhD, and then in a very high throughput way, test to see which chemotherapeutic drugs or other small molecules may work. And this whole idea that maybe you can do that before then you would go on to clinical care. So it's out there in the popular press and people are thinking about it. But my mum's 97 and she likes to know what I do. And I was talking to her about this the other day. She's still with it and she still lives independently, and I'm very proud of her actually. And she asked me, well, what are you up to these days, Ricky? And I was talking about this. Well, what's with all this cancer, personalised cancer medicine stuff? So that's why the topic came about, and so I have to explain it to my mum and my kids and everyone else. And as I said, it's very topical at Peter Mac, because we are at this point of maybe trying to change the way that we look after our patients, the way we go about it. So I hope over the next, 35 minutes or so, we get something out of this. Please jump in and ask questions throughout, and it won't be too data heavy or anything like that. It's a lot about concepts. And a bit of a historical perspective on where we're at as well. So I did what you do these days. You go to ChatGPT and you punch in what is precision cancer medicine. And this is what comes up. It's also called precision oncology. And it's a new approach that customises cancer treatment based on the individual characteristics of each patient with their cancer, okay? So instead of using a one-size-fits-all method, and it will be a lot of that sort of jargon, that sort of terminology, precision cancer medicine uses the very information, the very detailed information, and most often it's the genetic information about what is happening with that person and their particular cancer, to then tailor and guide treatment options. So we're going from that population-based approach where you treat a certain population of people, a certain percentage will respond, and that's great if you're in the responding group. But if you're in the non-responding group, where does that leave you? What are your options? So it's a different mindset and a different way of thinking about things. And I must say, conceptually, we've had this idea for some time. It's just that we haven't had the wherewithal and the technology to actually go about it. And so conceptually, we've had this idea, that tailoring and personalising, approaches to treatment is something that would be better for our patients, but we haven't had the wherewithal and the technology to drive it. But we are, so technologically advanced these days that things that we could only ever dream of previously is possible. So on the top there is this whole idea about, as I said, the traditional treatment, the common way that we treat cancer. So you've got a population of people, and they're color coded over there to represent different individuals. They all get the same treatment. So this could be an example, for example, colorectal cancer. So you come in, the standard of care is drug X, you give it to them, and you've got some people who have a great effect, so they respond really well, some that have none, and some that actually have adverse events, adverse effects. So, but you don't know up front which of those people are going to respond in different ways. So in this idea, this more personalised medicine and personal approach, what you do actually is you get the information on each person up front and their cancer. And with that knowledge, you get a cohort of people who get one drug, you'll get a cohort of people who get a different drug, and you've got a cohort of people who get a different drug again. And the whole idea is that you reduce the adverse events and you get more exceptional responses, because we're all different. If you look around this room, we are all, quite different in some of our genetics. Fundamentally our genetics are the same, but there are subtle differences in our genes, and our cancers are all absolutely different, because cancer is a disease of a deranged genome. And that's what happens. So every single person's cancer is different to someone else's. So conceptually, to even think about everyone responding in the same way to a common drug when all of our cancers are different is really quite perverse if you think about it. And it's amazing that we've actually got to where we've got to now. So again, just thinking about this change in traditional medicine to more personalised medicine. So on the left-hand side, we've got the common way that cancer is being treated these days. So the idea, you either burn it out with radiation therapy, you poison it with chemotherapy, or you cut it out with surgery. That's the traditional three pillars of cancer medicine. But now recently, with the way that we use genetics to understand the genetics and the biology of cancer, we can come up, and I'll go through this later, with some smart drugs that are used to then try and work on those very genetic changes, those specific genetic changes that occur in the cancer. And now we've got immunotherapy, which has been a real game changer, because pardon me, because we know that the host immune system is not only set up to fight parasites and infectious diseases, but our host immune system is actually set up to prevent cancer and to fight cancer. And cancers are very good at evading the immune system and suppressing the immune system. So in the last 10 years or so, there's been this rapid change in the way that we fight cancer, and immunotherapy has now become really the fourth pillar of the way that we treat cancer. And I'll go through some of these in my talk. Okay, so let's look at precision oncology here and the different components of how we would go about this. So start here in the yellow box. So that's around risk assessment and determining one's risk for cancer. And as I said, cancer is a genetic disease. It's based on genetics. And based on our genomes, people can actually be predisposed to actually getting cancer, more predisposed than others, and I'll give you some examples of that. But we can do that risk assessment, and even on that basis, we may be able to prevent cancer in a way that we've never prevented it before, and I'll talk about that. Based on the genetics and the risk assessment, we can then go on and diagnose cancer in a more sophisticated way. We may then provide a prognostic outcome, an idea about how bad the cancer may be, how bad the patient may do. There's an area called pharmacogenomics that I'll go into in a second, and that's really around how people respond. And as I said before, there are some patients who had adverse events and adverse reactions to drugs, and we want to try and avoid that. So that's this whole idea about pharmacogenomics. There's treatment up the top, and treatment comes in different forms now, and I'll talk about that. And then there's monitoring and post-treatment care. And all of those things, if you think about it, should be done on an individual basis because we're all different. And I think, again, this is conceptually makes sense. In a healthcare system that we've got at the moment, it is very difficult to do. It's very expensive. But I think we've got now the technological wherewithal where we can rapidly increase the way that we do this, and we can do it at scale, and we can probably do it at cost. So we're getting there, but whether we're there yet or not, we'll decide. So genomic sequencing, the game changer. And this is where everything in medicine really changed. So in the 1990s, the US government started what's called the Human Genome Project. And they set about and they spent $3 billion, and it took 13 years to sequence the very first human genome. All the DNA code in one genome was sequenced. It was done in a global effort in the USA, UK, France, Germany, and Japan. And they had these factories set up to go and do this sequencing. Now, when Dave and I were doing science, if you could sequence 300 or 400 bases at a time, you're doing pretty well. And so they had to stitch together all these codes, all this code. Oh, thank you very much. Of a single genome of billions of base pairs. So it took 13 years and $3 billion to sequence the first human genome. And then there was a company called Celera that did the same thing. They started a bit later. They finished a little bit later, and they tried to patent it. So they tried to patent the human genome, and unfortunately that was chucked out. But this was the game changer because for the very first time, we had the genetic map, the genetic code of a human. So just with that information was really, the way we've changed medical science and medicine more broadly. So now go forward to 2025. We can sequence your genome. If you gave me a bit of a swab of your mouth or a bit of your skin, we could take it and we could sequence it for about $200 in about 2 days. Remarkable. I mean, that is just technology going like this. So now we can actually get the genetic information of every single individual. And so if we can get your normal genetic information, well, why not get the cancer genetic information? So, and as I'll show you in a minute, we can take biopsies, or even better, we can do what's called liquid biopsies. So we can take a sample of blood and we can sequence the genetic code of your cancer and compare that to your normal genetic code. So we know exactly what has gone wrong in your genes to drive that cancer. That is a game changer because we've got the information right there and then. And this is all about technology advances. It used to be, when we were doing science back in my day, if you got 300 base pairs of sequence, you were wrapped. Now, honours students are coming in and they're sequencing 3 genomes in a week. And that's the different scale. And it's remarkable. It really is quite remarkable just how this has taken us. So let's just think about prevention there and how we might be able to utilise this sort of information now, this sequencing information, to better prevent. So here we go. Okay. So what is cancer precision prevention? Sorry, the title's just dropped there. Well, it's not this. So we used to think about prevention, and it's a public health prevention, and this is hugely effective. Don't get me wrong. Slip, slop, slap campaign run by the cancer councils, plain paper packaging, hugely, hugely effective, massively effective at a population level. Stop people getting, sunburnt, stop people from smoking, you reduce cancer rates. that is massively effective, and we should continue to do it. And we should continue to be, really strong in our messaging about that. But there's other forms of prevention. So think about this, and this is based on the genetics. So as I said, there are certain people who are predisposed to cancer because in their normal genome, there are mutations in genes that are actually important for cancer. And the two best known are BRCA1, BRCA1, and BRCA2. So they're mutated in breast cancer at a very high rate. These genes are mutated in ovarian cancer at a high rate, but they also find mutations in these genes in pancreatic cancer and actually in prostate cancer. And what those genes do, so on the left-hand side is the proteins that are made from these genes, they repair DNA. And every single moment of every single day, our genome is being attacked. The DNA is being attacked, potentially broken, and our cells are very, very good at repairing that genetic damage. And these proteins, BRCA1 and BRCA2, are two of the proteins that do that. So you go out and you get sunburn, or you get exposed to some carcinogen, or just with your cells turning over, sometimes things go wrong and you get a break in your DNA. Well, BRCA1 and BRCA2 repair that. So when they're mutated and they no longer function, then that repair doesn't happen and you get then DNA damage that isn't repaired, and obviously that can lead to cancer. So this is this whole idea now that, okay, well, we now understand the genetic basis of this. We've got people who are predisposed to getting these cancers because of these genetic changes. What can we do about it? And as you know, you can have upfront mastectomies if you choose, or you can monitor people who have these genetic mutations at a higher rate. So you can prevent disease based on the genetics of them. And that's what happens. So that's precision prevention, right? It's not a population based, not slap. It is saying person X and Y and Z, you have BRCA1 or BRCA2 mutations. You are highly susceptible to getting breast cancer or ovarian cancer. So we're going to proactively treat you in a different way than we would the rest of the population. That's called precision prevention. And again, it's been a real game changer. There's a man by the name of Charlie Swanton, and he was actually here in Melbourne 2 weeks ago. He's from the Crick Institute in the UK, and Charlie is a very, very smart person and a lovely fellow. And he has come up with this notion that some people, actually many of us, we have mutations in genes that may predispose to cancer, but that's not enough for those people to eventually get cancer. You need another hit. You need something else that's happening. And commonly, what we've thought about is that second hit needs to be a genetic hit. It needs to be another gene that is then mutated, and then collectively, that's enough to take that cell over the edge and make it a cancerous cell. Well, Charlie did this beautiful study that was published in Nature last year. It had about 3 papers back to back in Nature. And the whole basis of that is that normal cells can have this mutation in a particular gene. The gene there is called EGF receptor 1, EGFR gene. And that can predispose patients to cancer, for lung cancer. But the second hit is not another genetic hit. The second hit is inflammation caused by air pollution. So Charlie did this amazing epidemiology study, and he worked out, he did the genetics on a huge population base in the UK and found all of those that had the EGF receptor mutation. And then he mapped onto it those areas in the UK that had high rates of pollution in industrial UK. Then they went and looked at that population and worked out that the chances of having cancer, lung cancer in those populations were massively elevated. And it was linked to the pollution causing inflammation. That was the next hit that worked with the genetic mutation to cause cancer. So how could you prevent cancer in that setting? Well, obviously, if you did the sequencing and worked out that people had these mutations in those genes, you could monitor where they live, what the air quality is like, and you could actually remove them from that situation, from that inflammatory state. And think about that. What a game changer that would be if you were told, listen, if you live in industrial Bristol or whatever the city is in the UK that has high pollution rates, the chance of you getting lung cancer are massively increased because you've got a genetic mutation that further increases your chances. So go and live in Cornwall or somewhere nice like that, or change the way that that you run your life. So changes to lifestyle linked to the genetic changes. So this is at a sophisticated level that we're now thinking about prevention that is different to the way we think about, previously slip, slop, slap and anti-cancer campaigns. So, amazing. Okay, diagnosis. So back in, say, 1990, if you went in and there was the prospect of you having cancer, there would be a biopsy taken. So a piece of the cancer would be removed, would be sent to the pathology lab, and a grey-haired old bloke would look down the microscope at the pathology slide and say, this looks like stage 2 breast cancer or stage 3 lung cancer, based on the pathology, the way it looked. Okay, and it's a very effective way to diagnose cancer, but it's the way it looks, right? There's not much sophistication to that. Or you could get, an early stage sort of image that would sort of say, well, okay, it looks like there's a spot there that looks like it's a cancer and it's in this spot. But that's all you would know at the time. So you get pathology or imaging. So fast forward now to 2025 and what we do. So now you get your biopsy and it goes to the pathology lab, but instead of someone only just looking down the microscope, and they still do that, they look down the microscope and do anatomical pathology and look at it and score it, but they also send it to the lab and they sequence it and they get the genetic information on that cancer. So as I said before, you know exactly what's happened. In addition, we're getting much smarter because you don't just have to take the biopsy. You can take 20 or 30 mil of blood and you can sequence the DNA that's in the blood because our cancers actually shed DNA into the bloodstream. So it's floating around. The DNA from the cancer is floating around and we can sequence that. And that's a much, much easier way to do the biopsy. It's called liquid biopsies. So now we can get the genetic information from a patient from their blood rather than having to go in and do a fine needle aspirate. Yep.
How do you know where the cancer's from?
Very good point. Because you do the imaging as well. So now you do very sophisticated PET imaging, and shown here on the right-hand side, you can see that cancer that's lighting up as that little bright spot down in the pelvic area. So that tells you where it is. And so then you can get that sort of information from the pathology and from the diagnostic imaging that gives you an idea of where the cancer may have come from. But a really good question. The beauty of taking blood samples too, when we do biopsies, you can do them serially. So you can do them at diagnosis, following the first stage of treatment, following the second stage of treatment, and you can see how well your therapy is going based on the way that the DNA is maybe going down, but also you can see whether the tumor is evolving and changing, and I'll talk about that in a second. So it's a very, very, highly sophisticated way of doing this. So this is modern day diagnosis. Molecular pathology to sequence the cancer, both from the biopsy itself and from the, as I said, a liquid biopsy, and this molecular imaging that gives you not an idea only of where the cancer is, but this sort of image is a way of identifying the metabolic state of the cancer, how fast it's growing. And so this is a way that we can measure the activity of the cancer as well. Okay, let's continue around the circle here. This whole idea of pharmacogenomics and what does that mean? And when I was talking to Mum the other day, she's like, oh, what does that mean? So again, you go to ChatGPT and it says it's a study of how the individual genetic makeup of a person affects their response to drugs. So it covers drug metabolism, right? So if certain genes influence how fast or slow a drug may be metabolized within an individual. And we may metabolize around, in this room, we may metabolize drugs in a different way, just based on our subtle changes in our genetic makeup. Drug efficacy. So some people may not respond to medication due to changes in their genetics, and indeed some cancers may not respond in the same way. And then there's adverse reactions. So some of us may be able to tolerate much higher doses of a certain drug compared to other people. So this is this whole idea of pharmacogenomics, understanding how we might be able to use drugs based on the genomics, again, of the individual. And so just shown at the top there is around how we might be able to use a therapeutic drug, not just to kill the tumor, but to understand the toxicity treatment and then tailor that for the individual again, based on your genetics, based on the individual makeup of every single person in the room. What am I doing here? Oh, just want to get onto this. This wasn't, I pitched this slide from off the internet. I was from a medical journal. But I wanted to put this whole idea about prehabilitation here. So this is an area at Peter Mac that we're thinking about a lot. And I like it because it does start to think about the patient, the person. You're not just a number, an ID number on your arm. You're not just, another person, the 50th person that's come into that clinic for the day. You're starting to think about the patient at the point that they're going to go in for their treatment. So we've gone through the diagnosis, we've understood what's happening, we may have some pharmacogenomic information about you, you're about to go into treatment. And I think about it this way. If you're going to run a marathon, you don't just wake up one day and say, I'm going to run a marathon. And for any of the people in the room who have gone through cancer treatment, or people who have, it's often said in that way. It's not a sprint, it is a marathon. It is something you need to endure, something that is really difficult and takes a long time, and it is going to test you. So think about people starting on the start line there, going to run the Melbourne Marathon. I guarantee you, every single person on that start line has got a different training program for them. They want to run at a different rate. They might have different body types. They may have high aerobic capacity or low aerobic capacity. Some may have injuries that they've got to deal with, but they tailor their treatment for running that marathon differently. So doesn't it make sense if we were going to put people through a clinical marathon through treatment, they would actually start to tailor their treatments according to who they are and what their personal circumstances are? So at Peter Mac, we do prehabilitation, but we still largely do it at a population level. Okay, you're going to go in for colorectal surgery. Well, we need to prepare you in a certain way. So there's an example here around head and neck cancer. So this would be a cancer that is in the back of the tongue, for example. So when you prepare a patient for that, it's not just that, okay, you're going to go in for your surgery, then you have radiation therapy, then you have chemo. Think about all the other things that we have to do to prepare that patient. We have to think about their oral care. We have to try and stop them from smoking and stop them from drinking alcohol because, that has contraindications for the cancer and for the treatment. We have to give them psychological support. We have to provide them with the right nutritional environment because they're not going to be able to eat in the right way. And we have to prepare them for the marathon. And actually, the more physically fit people are going into their therapy regime, the better their chances are of having a good recovery. So all of these things we need to think about, and all of these things should be based on individuals because everyone is probably going to be at a different stage of their physical capability and their mental capability and even their social capability to be able to deal with this. So again, this is part of precision cancer care. It's not just about the genetics, it's not just about the treatment. It's actually about the way that we manage patients, we prepare them pre-therapy and then post-therapy. Okay, treatment. So I wanted to give you a couple of vignettes now around how treatment has really changed from basically poisoning people within an inch of their lives. That's the way chemotherapy was produced in Boston at the Dana-Farber Cancer Institute. Where they took kids who had leukemia and they treated them with poison to within literally an inch of their lives. And the kids now started to respond, well, at least reasonably well, even though there were lots of downstream effects on those kids. But that's the way modern chemotherapy started. If you want to go and read the textbooks on it, it's quite remarkable, actually, that ethically they got that through. But here's an example of, really, it was the first example. I don't know whether, Davo, you were at the Lung Cancer Conference when this was presented for the first time, and I think it was the late 1990s, but it blew everyone away, this story. So in the 1960s, it was observed that there was this Philadelphia chromosome in patients who had chronic myeloid leukemia. And it was actually done old school pathology way, looking down the microscope at chromosome spreads. And there was this odd looking chromosome out of the 46 that are there, right? And it's called the Philadelphia chromosome because they discovered it in a lab in Philadelphia. So that's all they knew. In the 1970s, there was a woman by the name of Janet Rowley, and she discovered that the Philadelphia chromosome had occurred because one piece of a chromosome, chromosome 9, had broken off and translocated and been stuck onto another chromosome, chromosome 22. So that's shown over here. Chromosome 9, chromosome 22, and there's been a bit of this that's been stuck onto that, and a bit of this that's been stuck onto there, right? That never normally happens. So it's called a chromosomal translocation. And so that funny looking thing there on the right-hand side is the Philadelphia chromosome. That's what they could see down the microscope. So that's what they knew. So, okay, there was a genetic basis to this. In the 1980s, it was discovered that there is now a protein that occurs that takes a little bit of the genetic information from chromosome 9, called the BCR protein, and sticks it to the genetic information on chromosome 22, the ABL gene, and you make this what's called a fusion protein, an abnormal protein that never exists in nature normally. So it's called BCR-ABL. And it is this protein that is causing that form of leukemia. Okay, that's great. So we sort of knew that that's what happened. We tested it in mice, and if you put that strange protein or the gene that encodes that strange protein into mice and into mouse cells, those mice now got chronic myeloid leukemia. So we had the genetic basis of the disease. We knew what was happening. We knew how it was occurring. What do we do with that information? And there was a physician called Brian Drucker, and he said, oh, interesting. Novartis, a pharmaceutical company, had made a drug that was against this ABL part of the protein for a completely different reason, not for this at all. And he thought, what if I used that drug and inhibited the activity of that protein? What would happen to the chronic myeloid leukemia? And what happened was the leukemias melted away. And I remember being at this conference down at Lorne. They run this Lorne Cancer Conference, and this guy, Brian Drucker, was there, and he presented the data, and it was remarkable. It was probably the first time we'd ever seen true precision medicine, understanding the genetics, understanding how that occurred, making a drug that was specific for that genetic change, and it worked. And it became so famous it got on the front cover of Time magazine. And it was, again, a game breaker, a game changer here. And so these idea of smart drugs, now came into vogue. And imatinib or Gleevec was the first of that. The other area is around HER2 and breast cancer. And we know now that in breast cancer, it's staged and you can be HER2 positive or HER2 negative. Okay, so just a little bit of background on that. So in the 1980s, HER2 was discovered, and we identified that there was this protein called HER2, human epidermal growth factor receptor 2. It's a gene that can drive growth in certain breast cancers. And it's amplified, so the gene is amplified, it's expressed at a much higher level in around 10 or 20% of all cancers. And that these women who have this HER2 positive breast cancer have a much poorer outcome, a poorer prognosis than women who are HER2 negative or HER2 low. So they'd linked it to cancer. It wasn't caused through a chromosomal translocation, it was caused because the gene was being overexpressed, it was being amplified. So then a company called Genentech showed that overexpression of HER2 contributes to cancer proliferation, and they made an antibody, which is a type of immune molecule that could bind to the HER2 and block its signaling and block the way that it functioned. So that antibody was called Herceptin, And now this antibody was shown in clinical trials to be effective against patients that had HER2 amplification. And so this is another form of personalised medicine. It's not a small molecule drug. It's an antibody, an immune-based therapy that is now commonly used. And if you are diagnosed with breast cancer, your HER2 levels are then determined. And if you're HER2 positive, you get Herceptin. So again, this more personalised approach. And then finally, I wanted to tell you about immunotherapy. This is a form of immunotherapy called cellular immunotherapy or CAR T-cell therapy. You might have heard about it in the news over the last few years. And this is something that colleagues of mine, Peter Mac and elsewhere, have been working on for a number of years. And the whole idea is that we take our immune cells, so our T cells are our natural immune cells that are there to fight viruses and other pathogens, and we can genetically manipulate them. So they'll basically have a homing beacon on them. That's why I sort of describe it to people. It's like a homing beacon that we now put onto those T cells, our normal T cells. And the homing beacon is to a molecule that is specifically expressed on a cancer cell. Okay? Then we put those T cells, so we put this on, and then we put those T cells back into the patient, and we hope now that those T cells will then circulate around the body and find those cancer cells and kill them. And so the way that we do it at Peter Mac at the moment is that we have patients with cancer. We then take their blood, we put it into the laboratory, we separate the T cells, we use genetic manipulation to express this homing beacon. We grow the cells up to massive numbers, millions and millions and millions of cells. We put them back into that same patient, and we hope to God that those so-called CAR T cells are going to go in and do their job. It's a single dose, single therapy. Patients only ever get it once. So here's an example, and this is the poster child for CAR T cell treatment. So this is a young girl. She was 5 years old when she was diagnosed with acute lymphoblastic leukemia, and she went through standard chemotherapy. So in 90% of patients, again, population-based, she got standard of care chemotherapy. 90% of kids respond really well to this. Unfortunately, she didn't, so she relapsed. She had more aggressive chemo, 30% cancer cure, relapsed again. Had a bone marrow transplant, relapsed again, no remission at all. Then she wanted this CAR T cell therapy. And as I said, she's the poster child. So that's her down there on the left-hand side when she went into her treatment. And they followed her now for 10 years. And you can just see she's grown into a young, wonderful young woman. This is her own immune cells that have been taken out, genetically manipulated in the lab, grown up to large numbers, and put back into it. One treatment only. So this is not science fiction. This happens now. I mean, we make the cells just down the road here at Peter Mac. We've got now 14 clean rooms, and we do this now for leukemia, lymphoma, and multiple myeloma. And it's remarkable, and doesn't work in all cases as well as this, but it works in the majority of cases for these sorts of cancers. It doesn't work so well for solid cancers yet, but for so-called liquid cancers like leukemia, lymphoma, and multiple myeloma, it works quite well. It's a very expensive treatment. It costs about $500,000 if it's not on the PBS, which it now is. So our government sponsors the sale of that. But you can just see that sort of response. And again, this is personalised medicine because that homing beacon that we put on the T cells was for something that was expressed on the cancer cells of this young woman. As I said, we manufacture it here. So finally, monitoring. And we go back to the way that we spoke about diagnosis. The same way that we diagnose cancer, we now monitor cancer in the same way. So those genetic blood tests that I spoke about, we now do that over the treatment cycle. So shown, let me see down here. Okay, so we've got a patient and they have circulating tumor DNA. That's what that stands for. They've got high levels of this cancer DNA that you can detect in the blood. In your treatment, it can be surgery, it can be other forms of treatment, and that'll drop down. And the patient will now respond, but then they'll relapse. And you'll treat again, and the circulating tumor DNA will go down, and then it'll come up again. So we can predict that patient is going to relapse, and you treat again, and it'll go down, And unfortunately, in some patients, it goes up again and they're not responding to treatment. So we can monitor their disease, not by how the patient feels, but actually by, sorry, the amount of cancer DNA that we can find in their blood. And it's not just the amounts, it's the type. And when patients get treated, it's like evolutionary pressure. You put cancers under pressure by treating them with a certain drug, they're very smart. They'll find a way to get around that. They'll evolve. Cancers evolve under pressure, under chemotherapy pressure, and they'll form other mutations to evolve away and now become resistant to that form of treatment. So you might treat them with something else. So we can use this sort of diagnosis methodology, this molecular pathology way, these blood tests, to now monitor disease over time. And again, that's a game changer because we can monitor our patients in a more sophisticated way, and we can also monitor them much better using molecular imaging and monitor the disease again over time. So here's a patient here. This is the primary cancer. It was treated, so that's going away. Another one came up here. I got on a different sort of therapy, and now you can see, those tumors are now essentially gone. So you can monitor it, using non-invasive techniques, which again is a game changer. So what's next? COVID was horrible for a whole range of different reasons, but from a medical technology perspective, it was quite amazing. I mean, we got, in 12 or 14 months, we went from understanding that there's this virus out there that is killing people to actually having an mRNA or 2 mRNA-based vaccines. It's actually a force of nature that happened. Remarkable pooling of resources across the world. And the game changer here was the technology. So these are mRNA-based vaccines that were used at scale for the very first time. So that exact same technology now is being applied to make cancer vaccines. So again, we've got the genetic information, we know what's wrong. And if you think about it, that cancer DNA is foreign. It's not normal. There are mutations there that the body should see as being foreign, just like a virus. Yet there's a way that the cancer's evaded that. So can we actually then use that bit of DNA, that foreign DNA, in the same way as we've used the COVID mRNA for COVID vaccines? And that's what's happening now. So there's mRNA vaccines that are now being tested, both at Peter Mac and elsewhere, to see whether we can actually use that same technology to vaccinate people for their particular cancer. And there's multi-omics. So I spoke about genomics and understanding what's going on with the genomes of those cancers. Well, there's all sorts of other forms of omics that will give us much more sophisticated information about that particular cancer. At a protein level, at the metabolic level, at the lipid level, all sorts of different levels. And so these are what is happening in the laboratory space. So we get that information, that very detailed information on the cancer. So that's a multi-omics approach. So this is what's coming at us. And, I'm sure in the popular press in the next few years, you'll probably see things around cancer vaccines. You'll see things around multi-omics approaches to treating cancer. So this is my final slide. So are we there yet, is the question. And I think theoretically we are. At small scale, we are. But at population scale, we are not. It's not like if you're a patient, you walk into Peter Mac and you get all of this. You might get some of it. You might get some of it sometimes, because it's not that we don't want to do it. It's that we don't have the right amount of funding and we don't have the right amount of people, and we probably don't have the right technology yet to do all of it. But theoretically, that's what we should do. It's exactly what the population and I think society should expect, that's where modern medicine is going. And it'd be wonderful. I think that would be a complete game changer. Can we do it in the Western world? Yes, probably. Can we do it in other countries and other jurisdictions? That's another question. And it's a question, I think, for society to start to think about and how we do that at scale. But anyway, so I'll stop there, and I'm happy to take questions, but I hope it's given you some insight into what we're thinking about, some of the wonders of technology and how that's driven us, and hopefully a bit of an idea about where we think, cancer medicine is going in the future. Thanks very much.
I'll take chairman's privilege and ask the first question.
Sure.
So CAR T cells against CD19 and CD20, the B cell lineage tumors, is fantastic because there are those tumor-specific antigens.
Yeah.
So what are some other currently known tumor-specific antigens, or which ones do you hope for so that it can be brought to other sorts of malignancies?
Yeah, so good question, Davo. So as I said, this works extremely well in certain cancers like those leukemias and lymphomas that have these very specific antigens. It is much harder to find them for things like colorectal cancer. It's interesting. So HER2 is one. So just as we've got Herceptin against the HER2 protein, we can make CAR T cells against that same strange HER2 molecule. And those CAR T cells, at least in some of the preclinical work that we're doing, works better than Herceptin. So I think that's one area. One thing that we've understood, though, is that the environment of a cancer in your liver is much different to the environment of a cancer in your blood. And the immune suppressive environment in the solid organs is much, much more difficult than in your blood, in the lymphoid organs. And there's immune suppressive activities in our solid cancers that are making it much more difficult for CAR T cells to be effective. So I think we've got a ways to go there.